Alright, so we're going to start. So today is the last grand rounds of the 2014-2015 academic year, and we're going to finish up with Dr. Jane Distad. Ooh, we have crickets in the audience. The couple things that I was told to mention is that Sumi and I are celebrating the court case of King versus Burwell.
We all are.
All right. The audience is not as enthusiastic as Sumi is. I wanted to thank a couple of people, and that thank you slide is gone. But I want to thank Megan Shade, Stephanie Guerrero, and Jessica Kleinbeck for all their organization of grand rounds, and also they organized the poster symposium. I also think that we want to make sure to thank the department for help funding the grand round series. And the last thing is we wanted to thank a couple of unrestricted educational grants, such as Walgreens Infusion Services and New Factor Infusion Services, for their help. So today, our last speaker of the year is Dr. Jane Distad. She hails from Ohio and went to Medical College of Ohio. She did her residency at Colorado University, then came out to Seattle region, and then did a neuromuscle fellowship at Stanford University and came back and joined the department. She is now an associate professor in the Department of Neurology, and today she's going to be talking about chemo neuropathy. So thanks, Jane. Thanks for coming.
Yeah. Thanks, Leo. Thanks for inviting me. So my first educational point, so that you can't say you didn't get any, is it's University of Colorado, but they say CU. So everybody knows. But here we know they say CU. UW and University of Washington, we know what we're doing. So I chose this topic with some help and also interest in the neuropathies. I imagine everybody's had similar frustration with seeing patients with neuropathy and many times not having a lot to offer them. So I'm delving into this topic a little bit, thinking about how this may connect with things that we do maybe earlier in treatment and staging of things. So first I'm going to talk a little bit about epidemiology as best as I can. I'll go into depth a little bit with some of the mechanisms thought to play a role in the toxicity of the nerves, touch on treatment and any ideas for prevention, and then I have a couple cases that Leo and I saw with one of the study drugs. And my suggestion for the future. So first, as background, as far as determining who has neuropathy and who does not, it's a little bit complicated because there's so many different rating systems. As far as the National Cancer Institute, they have common terminology and they agree on that use, but all the studies that I looked at all had different gradings, including a neurophysiological assessment for neuropathy. This is a breakdown of kind of what types of neuropathy we'll see that may be helpful for you determining perhaps does this patient have a neuropathy related to medication or something else. So the majority of them have sensory predominant or pure sensory symptoms. You can see the list of the common implicated agents on the left. And I'll talk a little bit more in depth as I get to each of the categories of agents. Suretny and his group in Edinburgh looked at 31 studies and did a systematic review and meta-analysis, including data on more than 4,000 patients. As I've already suggested, the measurements on neuropathy differed greatly. The timing of evaluations varied. And taking all comers and doing an aggregate prevalence, it was about 48% of patients treated and reported in these studies. The CIPN is for chemotherapy-induced peripheral neuropathy. I put chemo in quotes because they're not all necessarily considered chemotherapeutic agents, not in the classic way that we think of them. So looking at the prevalence after chemotherapy in this meta-analysis, 68% of patients had neuropathy in the first month based on whatever category that study used to measure what neuropathy was. At 3 months, 60%, and at 6 months, 30%, at which point I would be thinking this is more continual and relatively permanent. This is a very busy slide, but what I did was I pulled out the common things, and so hot pink is oxyplatin. And I put this up here because they've included the incidence of the neuropathy, the type of cancers, and then they also included the dose, milligram per meter squared. And if you see, for example, with the pacitaxel, there's a pretty high dose, and only 62% of those patients were reported to have neuropathy. And if you look at some of the higher incidences, then around 90% here and here, these are with the oxyplatin, and the doses of that vary significantly. But sometimes it's even a low dose that's given and is associated with a high rate of neuropathy. There's a very small percentage in one of the studies, 12% with cisplatin, and it was still a pretty significant dose. So more for reference than to memorize. So I pulled the studies from that table and included them on here. So oxaliplatin appeared in isolation in 12 of the studies, and the incidence between those studies, 40 to 90%. All of those cases were for colorectal cancer. And then cisplatin was the second most common named in isolation. There were 9 cases of that. Used to treat multiple different types, but there's a huge variation in the incidence of neuropathy in cisplatin. The pacitaxel, mostly used in breast cancer, ranges were around 60 to 90%. So you can see throughout these there's a pretty similar pattern, and I would say surprisingly lower in cisplatin than in other scenarios. And there's just one study with these, but the bortezomib and thalidomide had a very high rate of neuropathy associated with treatment in multiple myeloma. Of these 31 studies, they found 4 that had reported on genetic risk factors, looking at exons, and there were 13 different types of polymorphisms involved in repair mechanisms and inflammation of the peripheral nervous system. They weren't specific neurological disorders with which I was familiar. They also looked at other risk factors, and again, this is a compilation of studies, but they identified that baseline neuropathy, no surprise there. If patients had more pain symptoms or a hyperalgesic response to cold, they were more likely to develop neuropathy. Smoking and then an abnormal creatinine clearance. If you're not clearing the medication, I think it's not a surprise that it may be more toxic. So why does this happen? I imagine if you're damaging cells, cancer cells, you can damage other cells. Why the predilection to the nervous system? So the dorsal root ganglia are the primary target, source, and connection between the majority of these scenarios where toxicity affects the nerves. They lack an effective blood-brain barrier, which makes them very susceptible. There are also signs of toxic changes in the nucleoli of the dorsal root ganglia, but also other organelles, and the platinum-induced platination compounds with the DNA cause damage to the nucleoli, which ultimately affects transcription. Taxanes and vinca alkaloids, those accumulate significantly in the dorsal root ganglia, and again produce nucleolar abnormalities and impact neurofilament aggregation. Microtubular structures are important through with taxanes, Ortez, and the vinca alkaloids. And axonal transport is altered in those cases, so trophic factors, energy mechanisms can be a long-term negative impact on the nerve, and ultimately you can have Wallerian degeneration with those agents. And damage of the intracellular organelles, specifically the mitochondria, your energy, is impacted with these varying agents. The next slide is extremely busy, but you can see that there are a lot of different ideas and some information to support those. As a link between the agent used and neuropathy, so endoplasmic reticulum effect affecting peripheral vasculature, dysfunction in sodium channels, alterations in proteins specifically involving calcium signaling, transient receptor potentials, and expression changes in those, and they're linked to glutamate and glutamate signaling. The overexpression of mitogen-activated protein kinases, increase in pro-inflammatory cytokines, and the production of oxygen-free radicals have all been implicated. I'm next going to break down into my talk into the major groups and talk a little bit more in depth about some of the more common or more likely mechanisms. So with taxanes such as paclitaxel and docetaxel, I don't say these words normally, so my apologies if I'm mispronouncing them. So the most important drugs in breast cancer treatment are the taxanes, so that's one of the reasons why they continue to be used, both for disease-free as well as overall survival. They will cause neuronal damage affecting axons, the myelin, as well as the DRG. Their impact on the microtubules will interfere with mitosis and intracellular transport, protein substances, and trophic factors, and that affects the axons as well as the cells and axonal transport. When the microtubule transport system is damaged, we see apoptosis. More than 80% of the patients, depending on what study you look at, treated with the taxanes will develop neuropathy. And it can impact treatment as well, not just the neuropathy impacting their lives from there on out, but also whether or not they continue that treatment. Most commonly with the taxanes, we see a distal sensory neuropathy involving the hands and the feet. And these are difficult to sort out from other causes of neuropathy. Pain is very severe in about 25% of individuals that develop the neuropathy. And the symptoms can occur during the time that you receive the chemotherapy, increasing until it's discontinued, but they can last 4 years or longer. And again, I'm going to argue if they're still persistent after 4 years, they're not going to go away. If there's a significant neuropathy, the dose is decreased or the agent is discontinued completely.
How long after you stop one of these chemotherapeutic agents can you get a neuropathy? I mean, can there be a delay rather than having it occur?
Yeah. The next topic is a platinum-based, and that's where we see them more often, but it can be months out. That's very uncommon. Usually it's during therapy. So this is a very nice model of the impact of, this is paclitaxel in this case, the impact on mitochondria, calcium signaling, probably the more important, and then the transient receptor proteins have a link to hyperalgesia. Inflammation, impaired neuronal growth related to the impact on impact from the toll-like receptors that are also implicated in the development of the neuropathy. And then stepping into a little bit more detail of one of the more common mechanisms, calcium signaling. So calcium is important in developing neuropathic pain on the basis of a couple things. If you use agents that are calcium channel antagonists, you reduce the neuropathic pain associated with paclitaxel. If you decrease the calcium concentration, whether it's intracellular or extracellular, you end up with reducing neuropathic pain. Calcium channels specifically have the alpha-2 delta subunit, and there's evidence that with paclitaxel treatment, there's actually an increase in the mRNA level from those subunits in the dorsal spinal cord. So you see the link between dorsal root ganglia, maybe the sensory nerve, and then even implicating involvement extending to the spinal cord. So the overall incidence, approximately for paclitaxel 60% and the other 15%. The most important triggering factor, the T is for taxane. Taxane-induced peripheral neuropathy is the accumulation of doses over the course of the chemotherapy, which is the case for most of these agents. The neurotoxic threshold is thought to be about 1,000 milligrams per meter squared for paclitaxel and 400 milligrams per meter squared for the other. I'm going to move on to platinum-based agents. These are used in treating solid tumors, breast, colon, lung, testicular cancers. And they're unique in that they interact with DNA and they form these platination DNA adducts. And that ultimately leads to apoptosis of the cancer cells, but also has a similar impact on neurons. Again, the DRG are the primary targets of these drugs. Apoptosis of the sensory neurons occurs. And I mentioned earlier about the impact on nucleoli and the effect on transcription in those cases that leads to damage. The chemically induced damage in the neurons also has impact on the DNA. Cisplatin, used for testicular, ovarian, small cell lung cancers. This is one of the more common platinum-based agents. And I mentioned already platination products that form between the DNA and the platinum with causing cross-links and looking at cumulative doses greater than 300 milligrams per meter squared. About 60% of those individuals will develop neuropathy, and 50 to 90% of patients with a higher dose, so a greater percentage of people with a dose over 500 milligrams per meter squared of the cisplatin develop neuropathy. It can persist in more than half of the people for up to 15 years after treatment cessation. Again, I'd be surprised if this is a measure of how long patients were looked at, not necessarily how long the neuropathy lasts. And on the nerve conduction studies, we see a reduction in the nerve potential amplitudes more than an impact on conduction velocity, which means axon loss as opposed to the myelin. The myelin has the role in speed and conduction velocities. So when myelin's affected predominantly, you have slow conduction. So in these cases, we have reduced responses, which indicates that we have axon loss. If in the rare cases where nerve biopsy has been performed with cisplatin, there's a loss of the large fibers and secondary damage to the myelin sheath, the primary issue being the loss of fibers. The platinum-based agents also form adducts with mitochondrial DNA and inhibit the replication of the mitochondrial DNA, impact transcription, and then cause abnormalities within the mitochondria of the DRG. They may also cause gradual energy failure within the mitochondria, and that's one of the reasons it's thought that we see prolonged toxicity associated with platinum-based agents, particularly cisplatin. There's a term used called coasting, in which case individuals are doing fine for a period of weeks to months after the agent's discontinued, and then you see the development of the neuropathy. Oxyplatin is the other commonly used platinum-based agent that's implicated in neurotoxicity. Also used for solid tumors, particularly colorectal tumors. If you remember that first slide, I showed you all of the treatments were for colorectal tumors. So there are, the unique feature of the oxaliplatin is that you have both an acute neurotoxicity and a chronic neurotoxicity. And the acute will reverse typically within 1 week and is thought to be more related to dysfunction of the voltage-gated sodium channels. The chronic neurological syndrome, as with other agents, is associated with a total cumulative dose as well as the dose intensity. Typically, the neuropathy persists through the treatment and in between treatments as well. The next comment was for Dr. Ransom. because it had something to do with glia, but he doesn't get it since he's not here. Vinca alkaloids. So vincristine, I'm sure everybody's familiar with. This produces both sensory as well as motor dysfunction, so it's one of the agents in which we more commonly see motor involvement. The incidence and severity is associated with the total cumulative dose as well as the duration of dosing. The mechanism of action involves binding to beta tubulin. This leads to aborted cell division and death. So another mechanism for apoptosis. Disruption of the beta tubulin assembly leads to alterations in the microtubules within the axons, with resultant axonal swelling, nerve damage. There's also an increased responsiveness to C fiber nociceptors. Mechanisms implicated include the action on opioid receptors, as well as spinal synaptic plasticity, and the impact on central glia, pro-inflammatory cytokine release, serotonin transporters, calcium signaling, we've heard that before, and then the MAP kinases. Going into a little bit more detail about one of the mechanisms, so the opioid receptors in the spinal cord play a critical role with the vinca alkaloids in modulating the nociceptor transmission. The endogenous opiate peptides EM1 and EM2 are endogenous ligands of the mu-opioid receptor. And what is seen is with decreasing levels of the EM2 in the spinal cord and the dorsal root ganglia in animals, we see more pain developing, central sensitization in these situations, and leading ultimately in a loop around back to the C fibers and leading to hypersensitivity in those receptors. Also, the dorsal horn of the spinal cord manifests abnormal activities and activity in the neurons there. So with the vincristine-induced peripheral neuropathy, also dose-dependent, 60% of patients can develop a clinically significant neuropathy with doses between 30 and 50 milligrams. Bilateral painful sensations, hypersensitivity, muscle cramps, distal weakness are seen. Proprioception and reflexes are affected, both being reduced. And autonomic dysfunction, which is not typically seen with these other agents, is also frequent with orthostatic hypotension, constipation, and erectile dysfunction, and rarely even some cranial nerve palsies. The last category I'm going to talk about is the proteasome inhibitor, bortezomib. This is very useful against multiple myeloma and is also used with some solid tumors. Initially it was an inflammation inhibitor, but evidence for the cytotoxic effects of it led to the treatment in advanced myeloma. It will inhibit protein degradation, binding specifically and reversibly to the 26S proteasome subunit, causing inhibition of the cell cycle and apoptosis. This is used most commonly with other agents and is significantly limited by the onset of severe painful neuropathy. Paresthesias, dysesthesias, numbness, and impaired vibration and proprioception are common, so that's sensory impairment across the board. Peripheral neuropathy occurs in a range between 30% and 54% significantly, and more mildly in about 75% of individuals, and this is linked to cumulative dose. With the bortezomib, reversals seen within about 3 months following discontinuation of this in the majority of cases. So the mechanism involves tubulin polymerization, mitochondria, so toxicity to the mitochondria, inflammation, oxidative stress, glutamate, and the transient receptor proteins. I've kind of touched on most of those, probably to a painful degree. So this is a list of the agents, some of which I didn't go over. Carboplatin is not as commonly associated with neuropathy as are the other agents, and there's more than just vincristine, but that's one of the most commonly used ones, at least that I see. So all these individuals are developing neuropathy. Sometimes the agents are very effective for treating the cancers and potentially curative in some situations. So there have been a number of different efforts on a small case basis to look at the neuroprotective strategies. What can we do and use either with, before, or after using the chemotherapeutic agents to help minimize the negative impact on the nerves, particularly the sensory neurons. So list of the antioxidants, glutamine, gabapentin, etc. And the bottom line is there's no agent that's been studied with enough numbers, power, or effect to suggest that anything that we have available is effective in altering the outcome with therapy. And this is specifically related to taxane-induced neuropathy. These are a number of agents that have been looked at for taxane neuropathy, and in the table what I did was I included the number of patients that they actually looked at, and then what they indicated was their outcome with the use of the medications. I think that our need to help people can at times lead us to use some of these agents with the hope that something will change and the outcome will be better. However, there isn't any real clear evidence that some of these agents have any impact. What I put on more on the bottom of the list was things that I would consider more involved in reducing pain.
Okay.
Yeah.
Can you go back one slide? The first one you had up there, the vitamin E, certainly looks good with a lot of patients and a huge difference between taxane and controls. So that didn't meet significance?
It did not. And this is looking at trials of agents in chemotherapy-induced peripheral neuropathy as opposed to the taxane-induced. Minocycline, pregabalin, venlafaxine, L-carnitine, ginger, etc. And then also looking at the primary endpoint. There was not a significant difference in these cases with outcome on neuropathy.
These were given while the chemo is going? Or
Yeah, consequent with simultaneously with chemotherapy, the agents are given. So the first case that I wanted to talk about is a patient that I saw that came into the EMG suite, actually that Jean Hu had referred. At that time he was 67 years old and he had what they refer to as castration-resistant metastatic prostate cancer. And over 2 months, he had some prior complaints of fatigue, but it was really over 2 months that he had lower extremity and then upper extremity weakness and sensory changes in his hands. He was on a study drug of OGX-427, which is a second-generation antisense oligonucleotide. But he did have a history of diabetes, and he did have a history of diabetic neuropathy in regard to numb feet. Laboratory studies, SPEP, immunofixation, perineoplastic panel, RPR, sedimentation rate, vitamin B12, vitamin E, those were all normal. He did have vertebral metastatic disease, so there was some concern that there was compression. MRI did not disclose this, and also his reflexes were reduced. Somewhere along the line within this 2-month period, the study drug was discontinued. When I saw him, he had difficulty extending his knees against any resistance, was not able to raise his legs in hip flexion against gravity. His distal strength was not as bad with ankle dorsiflexion, and then knee flexion and hip extension were mildly reduced, but he could not stand. And that's what I remember. He could not get out of the wheelchair and into the bed. And I didn't understand how he was functioning like this. So I'll talk to you about his nerve conduction testing, which led to CSF evaluation. As I mentioned, he didn't have any reflexes and his vibration sense was diminished. But he had no white cells, glucose, and he had a protein of 167, so greater than 45 is abnormal. These are his nerve conduction studies. So basically, we have tables divided into motor and sensory conduction. Probably can't see a thing, can you? Sorry. So the perineal and tibial on the left, so he has anything that start is abnormal. So the latency is prolonged, so time is demyelination. So he's got slowed conduction in left perineal, tibial, median, and ulnar motor nerves. His responses are also small, so there's evidence of probably secondary axon loss. His conduction velocities are pretty slow. They should be at least 36 meters per second, and he's in the 20s in the legs. And then in the arms, he's in the 40s and 30s. Typically, those are roughly greater than 46, greater than 50 meters per second. And the responses in his arms, the amplitudes are normal, and there's just signs of demyelination. His F-wave studies, this is a late response, so we stimulate distally, look at the distal response, but also wait for the signal to go back to spinal cord through another interneuron and then back down to the muscle. So it allows us to study a longer length of nerve. And in these cases, it's very useful for demyelinating neuropathies such as Guillain-Barré or CIDP. And in his situation, his tibial minimum F-wave latency was close to 86, which is significantly abnormal. For a primary demyelinating process, we look at typically greater than 125% of the upper limit of normal in general. Similarly, the median and ulnar nerves also had significant prolongation of their minimum F-wave latencies. For his sensory studies, he had slowed conduction, so in the ulnar nerve it should be greater than 46, and he's at 33 meters per second. And also similarly with the median nerve, in this case, the amplitude is normal, so again, it's pointing to primary demyelination. And my note down there, since I ran out of space, his EMG was normal. And specifically, when we see what looks like axon loss here, this may also be manifestation of conduction block. And so we do look at the muscles with a needle examination. If we don't see any evidence of active denervation, it again supports that this is a primary demyelinating process. So I can tell you for this gentleman, he had convincing evidence of CIDP. His CSF protein was elevated. So CIDP based on his nerve conduction tests and then the elevation of CSF protein. So he got treated with IVIG. It took a long time for these things to get started. He didn't seem to have any response. I treated him with Cytoxan, plasma exchange for a period of 3 months. He didn't have any response. He was placed on steroids at a low dose for a period of time. Didn't have any response, and I think in the end I ended up treating him with rituximab, and he didn't have any response. So it was a very, very unfortunate situation for a tall guy that ended up not being able to walk and dependent on his wife. And he never wanted to go to a nursing home.
Okay.
Yeah.
So I just wanted to make a connection with the same patient that I had with the same OMG chemotherapy and a CIDP picture, and I treated with IVIG. He got better within a couple of weeks and went from bedbound to walking. Hasn't needed to continue the IVIG long term. It's more of a transit.
So my knowledge of this is very limited. So there was my case, and then there were 3 cases with CIDP, all treated with IVIG and responded. Yes.
So this treatment that Dr. Krause calls OMG, so is that this anti-sense therapy? Is that what?
I think he's thinking, oh my God, but it's really OGX. OGX 427.
But it's an antisense.
Yeah, it's antisense against HSP27.
Heat shock protein.
Oh, it's specific.
I apologize for my lack of repeating questions, but what was raised is that this particular treatment is OGX 427, and other trials it's been called apoptosis. It's a second generation antisense oligonucleotide, and it inhibits expression of the heat shock protein 27, which is a small ATP dependent HSP, which is highly conserved across species. It's seen in prostate cancer and other malignancies, bladder, lung, pancreatic cancers. And cell stress, cytotoxic chemotherapy is also shown to increase the expression of this heat shock protein. And it seems to be the overexpression of this heat shock protein is associated with a resistant phenotype. So many of these individuals that, I don't know if the patient that you saw, Eric, also had this resistant prostate cancer. But it's used in a lot of scenarios in malignancies with resistant phenotype.
So this isn't necessarily sort of a toxic hit to the axon or the neuron.
For this particular patient, yeah. So what I postulate is it has some impact on both the myelin as well as the axon. So the next case, which is Leo's case, again, older gentleman, 73 years old, castration-resistant metastatic prostate cancer. He was on 4 months of this OGX 427, and he had distal numbness and tingling. So not the degree to which Eric and I discussed. And distal sensory loss below the knee, impaired vibration, weakness distally with a negative laboratory workup. And his studies, he had a little bit of demyelination, but he had more consistent evidence of axon loss with small responses, particularly manifest in the sensory studies. So all the sensory studies were either small or absent. So that would be the more common scenario we see with some of these chemotherapies. My understanding is there are at least 10 cases here where this agent, at University of Washington, where this agent was used and the patients developed this more common distal sensory predominant neuropathy. So I'm not sure I really repeated the question, but I think, as I always think, it's inherent in my answer. So the little bit that is understood about this OGX 427 is that, at least in some of the trials, if the dosing was 600 milligrams, patients better tolerated it, especially if it was in association with other chemotherapies, and fewer individuals ended up having neuropathy in association with that. So I think that's all that I have to say about that. I have a few other table slides that may be helpful, and I'm happy to print out or send out. But what I learned from reviewing all this is that the agents that we always think are associated with neuropathy, the chemotherapy agents, are still the same. The mechanisms are putative but pretty well understood. The vinca alkaloids, the taxanes, and the platinum base. But now there are some newer agents like the proteasome inhibitors, the bortezomib, and then this newer agent that inhibits heat shock protein. The disabling neuropathy reports are anywhere from 30% of individuals to 90% of individuals, and we know how much variability there can be in what constitutes disability for one person and for another person, but that's pretty significant and impacts their quality of life and certainly impacts healthcare cost. If you can imagine admitting the patient that I had over and over for Cytoxan treatment or IVIG treatment, His healthcare costs were out of this world. I think it's important to understand from the reviews is that there's a lot of variability in how we report and look at neuropathy with chemotherapy, and I think having a consistent measure is going to be very important in determining what we see and what we do about it. As far as risks, I talked about 4 studies that had some ideas of risks that included smoking, decreased creatinine clearance, neuropathy, and certainly if you're using combination chemotherapies that are known. But beyond that, the risk factors aren't very well understood. There's some information on genetics and polymorphisms that maybe that can be used to try to create individuals that may or may not respond to certain potential neuroprotective agents. The mechanism of toxicity overall, there's a link in most cases with the dorsal root ganglia. Calcium signaling, mitochondrial toxicity are also some of the prime mechanisms, and in the platinum-based agents also plasticity of the spinal cord is implicated. We don't have any effective treatment. The medications that we use to reduce neuropathic pain are similar between chemotherapy-induced pain as well as other forms. There are emerging agents that we don't know quite yet what they're going to do. I'm very interested in seeing what the outcome is with this, the study agent, because this is from 2012, and there's still not information specifically out about it in association with neuropathy. There are many individuals that develop neuropathy, so developing a register and then also looking at potentially large trials of preventive agents, those that have already been studied and possibly looked promising in small trials, or other ideas of neuroprotective agents that we might gather from other neurological disorders. The really nice reference and easy to read is the top one that's in Cancer Management Research from 2014. Oh, and then I have some other information, but any questions or comments? Yes, Tom.
So do these agents not cross the blood-brain barrier? Is that why there are no central effects? Or?
The question is, do these agents not cross the blood-brain barrier? So in some scenarios, there are central nervous system effects of some of the agents, and specifically the platinum-based. I don't know that I can answer that any better, but the entry zone is thought to be the blood-brain barrier at the level of the dorsal root ganglia. Do you have a response for that, Mark?
The platinums in general cross portal 1 to 2%. Taxanes cross very well, but the efflux pump takes them out as well. We didn't get out very fast. Vinca avoids plasma enough. Imids such as thalidomide, pomalidomide, all in the central nervous system like that. I think the proteasome inhibitors, bortezomib and alpizimib, second generation, also come into the central nervous system.
So,
Central nervous system correlates like the agents called synergy. I'm not sure what the brain is doing. So, chemobrain is that's a whole different subject. When we're talking about psychopathy, chronic psychopathy, chronic psychopathy, see mostly in lung survivors, mostly described in breast cancer patients.
so the answer to the question, crossing the blood-brain barrier, platinum agents and that cross at a low percentage, taxanes cross but are blocked by another mechanism.
Well, the ABC cassette efflux from the portal system dumps it out as glucose.
So it gets dumped out of the central nervous system. Vinca alkaloids don't really cross, nor does the proteasome inhibitors. Proteasome inhibitors do cross, but we haven't seen a lot of central nervous system impacts from that. And then the ones that I didn't talk about, like thalidomide, and they cross. And then I think John had a question, and so
Yeah, I was just wondering about dosing and the relationship between chemotherapy dosing and these effects, and whether dose reductions or increased time intervals between dosing is a strategy that's commonly used, and how often does this result in just not being able to treat the cancer or changing the drug entirely?
So the question is what is done in the scenarios of toxicity, nervous system toxicity, and specifically peripheral nervous system toxicity with these agents. So there is evidence that lowering the dose decreases the severity of the neuropathy. If you increase the length of time between treatments, I'm not aware that that makes a big difference as far as outcome. It's typically total duration and total dose impacting the neuropathy. And then you...
I can explain. So taxanes, typically pacitaxel, taxane, you give them once every 3 weeks. If it's fractionated, you give them a slightly lower dose and give them weekly. The effect on peripheral neuropathy is dramatically lessened. So, and that's the usual strategy for using that agent. Similarly with proteasome inhibitors, curiously, if delivery is given subcutaneously, as intravenously, as it's normally given, that also increases peripheral neuropathy. And that's an increasing strategy used for multiple myeloma, where this drug class is used sometimes.
Because you mentioned kidney function or dysfunction as a factor. I mean, are the drugs where that's a risk factor for chemotherapy-induced neuropathy, ones that are cleared specifically by renal analysis mostly, or is that not?
That's probably just unique for the class of drugs discussed for the platinum patients. In particular, cisplatin is really not an issue for vinca alkaloids in its proteasome inhibitors because they have a different mechanism of metabolism.
So additional answers to the question from Dr. Chamberlain. Strategy of decreasing neuropathy in taxane use is decreasing the dose and giving it more often, and in bortezomib with the subcutaneous injection rather than IV administration. Sumi, did you want to go on the mic?
I had a question. So in the beginning, you had talked about some therapies for painful neuropathy and mentioned why neuropathy may be good, and then you mentioned calcium chelators. So is that something you can use for non-chemo-related, just neuropathic pain in general? Or can we do that? Or?
So calcium chelators were in reference to studies in animals and altering intracellular and extracellular concentrations of calcium, but not specifically in treatment of any type of neuropathy. And then there were 2 calcium antagonists, ethosuximide and then gabapentin, that were used that showed reduced pain in certain individuals. And in those situations, clearly we use gabapentin all the time for neuropathy, and calcium antagonism is thought to be one of the mechanisms of action. I've never used ethosuximide for neuropathy. So Mike and then Tom.
I actually had two questions. The first was, even though there's not much, there really isn't good evidence that any particular therapy prevents
chemotherapy-induced polyneuropathy. In patients that you see that are about to undergo it or in the midst of undergoing chemotherapy, and I guess it's my question for you, Mark, too. Do you ever say it's okay, maybe you could take alpha-lipoic acid or N-acetylcysteine or anything like that, or just say there's really nothing that we can do to potentially prevent it other than to keep the doses as low as we can keep them?
I only believe that happens in breast cancer patients, where some of these, I would say, homeopathic treatments are given with intent of preventing the evidence for that is weak to none. And I think we err on the side that more is better. In this instance, probably less is more.
The other question was, and I think Sid also raises, I came in late, so like him, I don't know if you talked about the risk of worsening, of unmasking CMT. You probably did. No, okay. But the other question was, you take into consideration, I mean, I think that's something that Sid's brought up, that Charcot-Marie-Tooth disease can be unmasked in patients who don't really know that they have it with certain chemotherapies. That's been reported. But how about patients with other pre-existing neuropathies? Do you tell patients that the risk of worsening neuropathy or having an exacerbation of neuropathy is greater if they already have diabetic neuropathy? You do. So they're much more likely to have problems with the chemotherapy. So Mark is shaking, said yes.
That's it from.
So Dr. Weiss and Dr. Gospi are asking about the risk factors and genetic risk factors. Earlier on in the talk, I reviewed a meta-analysis where they looked at over 4,000 patients in 31 different studies. And in that case, out of a small group of those studies, they found risk factors, genetic risk factors that were specifically polymorphisms. There were not, CMT was not included in here at all. But it is very clear that individuals with CMT are higher risk to develop neuropathy. But it's also true that anybody with an underlying neuropathy, at least in this meta-analysis, had a higher risk of developing chemo-related neuropathy. And the other things I mentioned was smoking and impaired creatinine clearance for those. And then, so repeating your first question might be a little bit.
Whether to pre-treat
Okay.
chemotherapy, using chemotherapy, with any kind of
You guys should just come up and use the microphone. So Dr. Weiss asked about pre-treatment in any individuals prior to undergoing chemotherapy, and Dr. Chamberlain indicated that there isn't really anything in patients, for example, that use home remedies, and particularly with breast cancer, it may be more of a problem. You didn't say that at all.
Not quite. I would say the context that we see preventative therapy started by oncologists is almost exclusively in the breast cancer population. I don't believe that we have any evidence that those preventative measures provide any benefit in diminishing the risk of general med population, taxane-related neuropathies.
And as far as those breast cancer patients with taxane-related neuropathies, are you talking about different homeopathic agents, or is there specific things that those patients go in, they're going to get treated for their breast cancer, and they all get vitamin E or vitamin C or?
Generally, they get over-the-counter medications to try to mitigate this, prescribed by their physicians.
Okay.
With no evidence and probably no benefit, but concern that this may be a problem.
So, in summary, from what Dr. Chamberlain said, that there are scenarios in which patients undergoing treatment with taxanes for their breast cancer do receive agents to try to mitigate the effect on the peripheral nervous system, and there's no evidence that they're of any benefit. Tom, did you have a question too?
No.
Okay. I think that's all I have.
Thanks.
Thanks for listening.